Hi, I'm Gordon Guyatt. I'm a specialist in internal medicine and I work at McMaster University. Most people, when they think about it carefully, pretty quickly realize that if you're deciding on the effectiveness of a treatment, a drug, or a physiotherapy, or the right nutrition, or a surgical therapy, that the best way to decide on the effectiveness is to get all of the highest quality evidence together. And when you think about it, I think most people would say, well, that's relatively obvious. You don't want to pick just one study here or one study there because by chance or because those studies may have been limited in some way, they could give aberrant or inaccurate, spurious, misleading results. And indeed, historically, when people did reviews of the literature, experts had their vested opinion. They believed that something was the case, and then they got invested in it, wanted to show other people. So you would have reviews that are very misleading in that they would cite or focus on a set of studies that were not representative or where their methods were weak. So the bottom line is, the last 20 years, I would say, there's been a growing realization, which now I think most people in the scientific community would agree with fairly strongly, that if we really want to know about the effectiveness of a particular treatment, we need to have an unbiased summary of all of the highest quality information. Well, what has also happened in the last 20 years is rules or guides or standards for making sure that we get the answer right to those questions as we try to gather the best high-quality information on the effectiveness of an intervention, be it a drug, other medical interventions, or surgical interventions. And those rules are things like a very explicit question that specifies the patient's interventions, comparators, and outcomes, a comprehensive search for the relevant literature, a methodologic criteria, which often for therapies is restricted to randomized trials, an evaluation of the risk of bias in those randomized trials, because some randomized trials that have concealed randomization, blinding, and complete follow-up have low risk of bias, and other randomized trials that are not concealed, no blinding, and high loss to follow-up will have high risk of bias. And then in the end, so you accumulate all the highest quality information, and then the meta-analysis part is the statistical analysis of what you do with that high quality unbiased information to generate a single estimate. So, and the last 20 years, as I say, have seen people realize that this is the best way to find out on the effectiveness of our treatments, and a gradual consensus expressed with the Cochrane collaboration, whose business it is to do these systematic reviews, and the goal to do it for all interventions that we know about. Anyway, a set of rules, people are now have accepted a set of rules for doing these procedures. So there are three things worth distinguishing, which is how one judges the risk of bias in an individual study, then whether people have done a good systematic review and meta-analysis, and then, having got the best information, what are the implications for a guideline? So, and the overall quality of evidence and the guideline. So, let's think first about individual studies. So we know that randomized trials are a lot better than observational studies. Randomized trials, when you allocate people to an intervention or control on the basis of a coin flip. That's much better than comparing people who, by their own decision or in consultation with a health provider, make the decision. And so a famous example is we had observational studies where women chose to take hormone replacement therapy or didn't, which suggested big cardiovascular risk reductions. And when people did randomized trials, at least for women distant from the menopause, there is no such effect, and in fact it goes in the other direction. So randomization as opposed to observational studies is a big criterion, and many systematic reviews will use that as an eligibility. In other words, if you're looking at effectiveness, you only take randomized trials and you reject anything that is not randomized. Then, let's say we're in that situation, randomized trials will be higher quality, lower risk of bias if they do the randomization properly. We call that concealed randomization. If they blind patients and caregivers to whether the patients are receiving the active or control, and complete follow-up. So you're in a much better situation if you follow all your patients than if you lose half of them. So those are the sort of standards we would apply to an individual study. You have all sorts of groups doing systematic reviews and summaries. The Cochrane collaboration is a worldwide collaboration dedicated to doing systematic reviews of all the medical therapies known to humankind. They now have upwards of 5,000 such reviews, and they think by the time they're done there'll be more than 10,000. That is really the biggest and most important group. But there are all sorts of other groups doing systematic reviews. There's the AHRQ in the United States doing evidence summaries, but most countries have their own health technology assessment. Canada has one, Scandinavian countries have one, and so on. So there's a whole people have now, as I say, accepted that these evidence summaries need to be done. Specialty societies, cardiology societies or hematology societies or whatever, sometimes they are engaging in doing this, or at least using them for their guidelines. So a wide variety of groups have adopted the methodology and with varying degrees of rigor are using them. Been all sorts of folks have got together and suggested standards for reviews. Once you have a review in front of you, the AMSTAR criteria, I would say, is the one validated system for looking at the quality of a systematic review. But I would have thought that the standards, I would have thought that if one were picking a single source for the standards of going about doing the review, one would go to the Cochrane Handbook. So the Cochrane Handbook is quite a lengthy document now, I think about 20 chapters, which takes you through every stage of doing a systematic review and meta-analysis. And I would have thought that most experts in the field would agree in things like the basic standards, which are a clear and explicit question with clear eligibility criteria, a comprehensive search, assessment of the quality, the risk of bias in the studies that you obtain, demonstration of duplicate assessment in judging studies for eligibility and in rating the risk of bias of the studies, generating, before you start, criteria that might explain variability in the results, and then appropriate standards for statistical analysis. And as I say, I think most people who are working in the field, who are experts, would agree basically in those criteria. And if I were picking one source to send people to say, okay, you're going to do a systematic review, how should you do it? I would send them to the Cochrane Handbook.